Hello, and thank you for joining the Systems for Action Research in Progress webinar. My name is Chris Lytle. I am Deputy Director of Systems for Action. S4A is a national research program of the Robert Wood Johnson Foundation, housed at the Colorado School of Public Health. We support studies across the country, testing tools and models to facilitate multi-sector collaboration across medical, social, and public health systems with a goal of improving population health and advancing health equity. Our ResProg webinar series serves as a platform for S4A investigators to share findings at various stages of their studies and provide commentary on the potential impact of putting their findings into action. Today, we are joined by Drs. Jeffrey Cohen and Carla Rash to introduce their new S4A study that tests how a transit system can enhance substance abuse treatment outcomes and reduce provider-level treatment costs for substance abuse in Connecticut. If you have any questions for our investigators, please enter them in the Q&A box, and we'll have time for questions at the end. We'll start out with the presentation from our two investigators, followed by commentary from Stephen Juliet. So our first presenter, Dr. Jeffrey Cohen, is an economist and UConn professor, an expert in transit and real estate with past empirical research that includes substance use, treatment costs, and other public health issues. Dr. Carla Rash, clinical psychologist. She's an addictions expert, and most of her research to date has been focused on efficacy trials of addictions treatments. And our commentator for today, Stephen Juliet, currently serves the Capital Region Council of Governments as the Public Health Emergency Preparedness Grant Manager and as the Metropolitan Medical Response System Project Manager in Hartford, Connecticut. He's also an adjunct instructor in Clark University's Department of Community Medicine. And with that, I will pass it over to the presenters. Thank you.
All right, so this is Carla Rash. I'm going to do a brief introduction and then let Dr. Cohen get into the meat of our project. So Dr. Cohen and I have already been introduced. We also have a co-investigator, Shane Murphy, who's also at the University of Connecticut. And then at the bottom there, our study staff also include Ruth Fetter, who's our research assistant on the project. On the right-hand side of the slide, you can see our very large advisory panel, which we're very excited about. The top four there, Recovery Network of Programs, Community Renewal Team, Wheeler Clinic, and The Village, are all community treatment providers here in Connecticut. And so they're representing the treatment side of the equation. And then on the bottom there, you can see our Connecticut department representative. So we have the Department of Mental Health and Addiction Services involved, as well as the Department of Public Health and the Department of Transportation. The reason our advisory panel scopes so many different areas is because we feel that input from both the treatment side as well as the State Department side is really critical to implementing any of the findings that we find as part of this project. We are very hopeful that this will result in real changes to our state. Next slide.
Okay, I think I might have skipped, I'm sorry. Oh, here we go. Go ahead.
So just a little bit on the background of where this project is coming from. Access to substance use treatment and mental health treatment are actually quite difficult for a lot of people in the US, and it ends up being quite a costly problem. So as addictions go untreated, they result in more emergency room admissions or overdoses and very costly issues. So getting people into treatment can save us as a society, more money in the long run. Another really important issue about access to treatment is that it's driving health disparities. So a lot of the structural barriers to treatment, such as transportation and access, as well as even ability to have childcare services, are related to socioeconomic statuses. So you see really large health disparities in the substance use treatment outcome literature. And this has been exacerbated by the recent opioid crisis, which is particularly bad in Connecticut. Connecticut is one of those top 10 affected states in a lot of the outcome measures of the opioid crisis. Now, I just wanted to give you a flavor of what this looks like. So I pulled some data there at the bottom from patients who had participated in one of our 5 recent clinical trials. So just under 1,200 patients from Connecticut and Western Massachusetts. Over half of them did not have a driver's license, and among those who did have a driver's license, 39% had no access to a vehicle. So you're looking at upwards of 75% of this very large sample of patients who don't really have access to reliable transportation unless it's a public transit system or some other mechanism. So let me just tell you why that's a problem. Someone who's initiating substance use treatment usually steps into a fairly intensive program called intensive outpatient treatment. That would be anywhere from 3 to 5 days a week that they're going to the clinic, and as they progress, they step down in frequency and intensity. So you're looking at frequent visits to the clinic, not weekly, not less than weekly, but 3 to 5 times per week that they have to arrange transportation. And patients in the opioid use substance disorder treatment area, they are often accessing a medication called methadone, and methadone treatment involves daily visits to the clinic, which is very time consuming and also can be difficult to arrange transportation reliably. So you can see that this is a real issue in the substance use treatment world. Next slide. So we believe that strong transit systems can improve both treatment outcomes and the clinic operating costs. So there's been some evidence that as the number of patients increases in a clinic, that it decreases their unit costs. However, there's wide variability in that number, and it's unknown why that variation occurs. And the net result of that is that it becomes difficult for state agencies to make decisions about limited resources when they don't know where the best impact or the most use of the resources can go. So the facility's proximity to transit may result in increased patient volume. So as more patients can access them, they may have more people walking through the door for the first time, which would be a good thing from the clinical side. Another thing that proximity to transit may impact is clinician time, specifically unbillable time. So I think of clinician time as sort of a fixed cost. The clinician is there whether the patients show up or not. So you're paying out money in clinician salary, regardless of whether you're making money in billable hours. And so this is the commonly called the no-show problem in addictions treatment. You have a lot of scheduled appointments in a given day, and sometimes it can be quite a high rate of no-show or missed appointments. So if we can reduce that, then treatment facilities may save more money. And we think that that proximity to transit will push down unit cost curves, which in Dr. Cohen's language is the economy of scale that we're looking at. And if integrated, these mental health and substance use services together under the same umbrella, that it may produce even further cost savings, which would be the economy of scope. Next, thank you. So getting to this particular project, we're aiming to use a quasi-experimental empirical estimation approach, and our specific aims are listed there. The first one is looking at how treatment costs differ before and after a new transit line or changes to the schedule occur. So in Connecticut, we had a very large initiative developed a few years ago that helped connect town to town. So most of our towns have local buses, but getting from town to town, which sometimes is required to access specific types of treatment, getting from town to town would be more difficult. There's few buses that go, they're infrequent, and scheduling can be a problem. So that new transit line that went into place in Connecticut is a really great opportunity to look at the before and after picture. Did treatment costs differ? And then we can also look at changes to the schedule. So this is a real clinical problem for our patients. When buses are infrequent, then they may have to wait a very long time before they can catch buses to the clinic or home. And when they miss a bus, that poses a very big problem. So you end up having patients just sitting around waiting for the next bus, and that gets frustrating and may lead to early treatment dropout, which we want to avoid. So if we can look at changes in frequency of service schedules, that's another opportunity to look at its impact on treatment costs. Our second aim there is to look at differences in how transit impacts provider costs for those who offer very limited substance use services versus comprehensive substance use services. So there are different stages of care for substance use treatment, and some providers cover the entire spectrum of care, and others provide a more limited subset of services. So we intend to look at that difference. Our third aim is to look at how transit can impact provider costs among those who offer just substance use services or just mental health services in isolation versus those who offer substance use and mental health services under the same umbrella. That's called integrated care. And then our last aim there is related to those transit improvements. We'd like to look at how the reduction in treatment costs from treating patients, hopefully it'll result in better treatment outcomes. And we'll look at those for those close to the providers versus further away. And one of the things that I'm interested in is how this impacts equity. Are more clients, more diverse clients able to access treatment and helping reduce those health disparities I discussed in the first slide? So we've pulled together a very comprehensive team. This is aligning them with those systems that are consistent with the S4A mission. So our medical side involves our treatment providers as well as the Department of Mental Health and Substance Use Services from the state of Connecticut. Our social sector representatives are the Department of Transportation as well as the Capital Region Council of Governments. And then our public sector involvement is from the Connecticut Department of Public Health, as well as that Capital Region Council of Governments.
Thank you, Carla. Can you all hear me?
Yes.
Okay. So what I'm going to show you is a map here of what the new bus rapid transit line that Dr. Rash mentioned looks like in terms of its geographic coverage. CT Fast Track is a bus rapid transit line that runs on a dedicated pathway that uses a extinct freight rail line. So there's no traffic that needs to be worried about. So people can know exactly when the buses are leaving and when they're supposed to get there, and they're remarkably on time because of the lack of traffic. It covers the 4 municipalities of New Britain, Newington, West Hartford, and Hartford. West Hartford is one of the towns where our discussant today, Steve Huliad, was the former director of health of that town. And so this is a remarkable introduction of new transit, as Dr. Rash mentioned, because of the fact that it enabled travel from town to town in Connecticut. And so as you can see, there's 11 different stations in this route, and it opened in March 2015. This map comes from a study that I've done in collaboration with the Connecticut Department of Transportation and the U.S. Department of Transportation on CT Fast Track. It's ongoing work. So the hope is that we'll see some evidence after the opening of the CT Fast Track line that for providers who are located near one of these yellow dots, we might see a decrease in their unit costs of operation compared with providers that are far from these yellow dots. As well as looking at after versus before the opening in March 2015. And we're fortunate to have some good data that I'll talk with you about in a couple of minutes that enables us to go back to at least 2012, if not maybe a little bit earlier than that. Another recent transportation initiative in the state that I've been working with the state DOT and the US DOT on is what's called the Hartford line. The Hartford line is a commuter rail line that goes all the way up to Springfield, Massachusetts, and it travels north-south through the entire state of Connecticut down to New Haven on the shore, which is on the bottom of the map here. So Enfield in the north, where Station 1 is the northernmost point in the state, and New Haven is the southernmost point. This runs on an existing Amtrak line, and it has dramatically increased the frequency of service connecting the entire state of Connecticut. And in fact, some people take CT Fast Track, the bus rapid transit, to right near where the station in Hartford is, and then they can hop on CT Rail, Hartford line, and go either north or south. This is particularly useful because of the fact that, again, it enables more travel between towns when you might not have been able to do that so easily without a car before the opening of the rail line. So that's something that we're going to try and leverage as well, looking at near versus far from these commuter rail stations, substance use treatment providers, looking at their operating costs, near versus far, before versus after the opening of the CT Rail Hartford line. Now, getting into a little bit of the nitty-gritty of what we're going to do in terms of our analysis here for looking at substance use treatment and operating costs. I promise I won't get too technical. We'll leave that for one of the next research in progress webinars that we do. But you might like to think, and some people have done this, as I'll mention when I show you some of the literature, that the substance use treatment process might be similar to, at least in a loose manner, it might be similar to the production process of many other types of goods and services, where you have different inputs into the production process, and here it's the treatment process. So you might have, you would have employees that would consist of clinicians, nurses, counselors, administrators, and you would have some physical capital, like buildings and structures and maybe office furniture. And you might have some other supplies, medications and supplies. Those are your other inputs. You take them and you combine them all together, and that generates what we call outputs that can comprise a number of different, they can be measured in a number of different ways, including treatment completions. That's one way to measure the output of this treatment process. Treatment outcomes are another way to possibly measure the output of the treatment process. So you might look at, for instance, whether or not people hold a job for a certain amount of time after treatment, whether or not they have a stable living situation. And there's several others that are available in the data sets that we're going to be using in our analysis. And another measure of output could be admissions and or discharges, although it's hard sometimes to look just at admissions and discharges in isolation, because that doesn't tell you a lot about the quality of the treatment as you would get with looking at completions or outcomes. But in some cases, it's additional information that gives us an idea of what these providers are doing and a way to measure it. So here's a visual demonstration of the treatment process and how on the left side you can see the different inputs. We talked about physical capital, buildings and structures, and possibly office furniture and workers. We talked about that. An additional element that we didn't include in the previous page, but is very important, is that of social services. So in this case, social services includes transit. If you take transit and you use that as something that's considered to be an input into the treatment process. You combine it with all of the other inputs, and then on the right side, you see what the outputs of the process are. And those are the outputs that we talked about. And not only do we have, for the outcomes in the last box in the bottom right, not only do we have the medical outcomes that we talked about, which include completions, for instance, but we also might have public health outcomes, which include how the opioid crisis might be changing over time. And our hope is that we'll see evidence of that changing for the better. So how are we going to go about doing this analysis? It sounds like there's a lot going on here. One way to do this analysis is by using something that's called cost function analysis. Cost function analysis uses a statistical approach called regression analysis, which enables you to look at how provider operating costs depend on a whole bunch of different things, including your outcomes and your outputs, as well as other factors that might be expected to affect your costs, like the wages of your employees, the cost of your physical capital. And we would also assume, we also tend to think that client mix would likely impact the operating costs as well. You would control for the mix of clients at the individual providers. So that's another factor that you would control for. It's a way of essentially sort of developing a controlled analysis without doing, say, a clinical trial where you have a control group that you use in your experiment. It's looking back at data that's already there and trying to use that as a way to estimate the relationship between provider operating costs and your outcomes. The other thing that we will do that's unique from what other people have done is we will control for proximity to transit. And in addition to proximity to transit, whether or not you're close or far from these new transit lines, we will look at how things are different after versus before the opening of the new transit lines. And that's the key here, because in recent years in empirical economic studies, people have placed a very high importance on what's called an identification strategy, or a way to try to make sure that you don't have causality going in both directions, in two directions here. And using something like this approach that we're going to use enables you to have a reasonable degree of confidence that you're estimating the impact of, say, improved outcomes on operating costs, or your outputs on operating costs. While this last type of additional part of this analysis has not been explored extensively in cost function analysis yet, there is a long-standing literature on cost function analysis, both in health-related applications as well as in other applications. For instance, Morrison and Schwartz in 1996 look at the operating costs of the U.S. manufacturing industry and look at the impacts of public infrastructure on the operating costs of the manufacturing industry, but they didn't quite use the type of identification strategy that we're using here. Cohen and Morrison-Paul in 2008 looked at the hospital sector in the state of Washington and looked at how what we call economies of scale might have been different in different hospitals throughout the state. And then, so I'm the Cohen and Morrison-Paul. Subsequent to that, I did a study with colleagues at Connecticut DPH to look at Connecticut hospitals, and it just demonstrates our long-standing relationship with DPH. Dr. Rash has a long-standing relationship with Department of Mental Health and Addiction Services, and then I have a close collaboration with the Connecticut DOT. So our linkages here go way back, and we're hoping to build on that based on the analysis that we do. As an aside, in a previous study, Cohen and Checo in 2017, as a part of another Robert Wood Johnson Foundation funded study that was through the National Coordinating Center for the Delivery and Cost Studies at the University of Kentucky, we looked at using cost function analysis as a way to measure whether or not it makes sense for local health departments to merge with each other or consider merging with each other, or to operate independently because of the fact that the scale of operation may be suboptimal. And that study was published in Health Services Research. And then the most relevant to our study is a study by Duffy et al. In 2004, which estimated a cost function using non-methadone substance use provider operating costs, and they used that as a way to try to get a handle on economies of scale and scope across a sample of approximately 200 providers throughout the United States, using survey data that was obtained from a federal agency that had done some collecting of that survey data. So that was one of the pioneering studies in substance use treatment costs analyses. And our study is different because we rely on data that's provided from, number one, from the state agency in Connecticut and also in a couple of other states that we're going to look at for generalizability, as well as we rely on financial data that comes from the Internal Revenue Service for many of these providers. So that's how some of the ways in which our analysis differs, but then we also have the identification strategy that hasn't, to our knowledge, been looked at carefully in the literature as to date. So just to tell you a little bit more background about this idea of the cost function, what is it trying to do? Well, you might think, let's say you have two different inputs, and so the scale on the right-hand side, you're trying to balance the extra output you get per dollar that you spend on capital with the extra output per dollar that you spend on workers. So you might think of this as the bang for the buck. Okay, so on the left side of the scale, based on this picture, it looks like the extra output per dollar that you spend on workers is greater than the extra output per dollar spent on capital. So what do you think you want to do? You want to use more workers in this case, and that's part of the decision that providers need to make when they're trying to balance these two different inputs. And so trying to find the ideal input mix is an important element of the decision making and the analysis that's underlying the cost function analysis. Now, as I mentioned, one of the new aspects here is the enhanced social services. They can tip the scale in one direction or the other. So in this case, transit might actually make the left side even more advantageous to use more workers, or it might even it out, and it might make it more likely to use that you'd want to use more capital. So adding in this additional factor here is a way to try and enable us to see, how does this important, very important enhancement of transit tip the scale in either direction? And without doing the analysis, we don't know. And that's one of the big things we're going to try to do with our statistical analysis. I promised you I wouldn't get too technical, but I want to basically show you something that is also another way to understand the idea of economies of scale that we're trying to look at. And Dr. Rash did an excellent job of describing the no-show issue, for instance. So ideally, the curve here that says average cost, or AC, that's the unit cost. That's the cost per patient. Typically, that is a U-shaped curve. We like to think it's a U-shaped curve. And where you want to be is you want to be at the bottom of the U-shaped curve with the output level of Y sub E. If you have a no-show problem, you're likely at point Y sub A, where the cost per patient is higher because you've got these clinicians who are sitting there for part of their day and not able to generate any output, or any outcomes for that time of day when they're sitting there without treating a patient. And so what would be ideal would be if they could move down the unit cost curve closer to point Y sub E. And so that's one of the things we're going to be looking for. Are the providers at a place like YA, or are they at a place more like YE? And how does that change after transit is introduced? Because here's one of the key things. If we see, for instance, that transit, introductions of new transit, or changes in transit schedules, or changes in transit stops, in some neighborhoods the stops might have moved either closer or further from the providers. If we see that happening, and if we see at the same time, if we see providers moving down towards the bottom of their unit cost curve, that's a rationale for saying, gee, maybe we should try to more broadly in the state of Connecticut and possibly elsewhere, help them coordinate and align these different systems, these transit systems, together with substance use treatment systems, as well as public health, because of the fact that one of the underlying threads here is that we want to try to alleviate the opioid crisis, in addition to trying to save money for providers. And then the other possibility that we don't know if this is what would happen or not is that you might be at a point like YB. So YB means you're also not at the bottom of your unit cost curve. That might be a situation where your organization gets so big that it's hard to coordinate. And so perhaps getting smaller would be the ideal. And in that case, you might not think that having transit aligned would be the right thing to do, because that would in some ways possibly make it more difficult for you to shrink your scale of operation. So a point like YA is what we call economies of scale. YB is what we call diseconomies of scale, and YE is efficient unit of scale. So this is going to be the underlying theory behind the statistical analysis that we're going to do in our study, which then later on will be brought back to our advisory panel for us all to discuss what should we do to try to align systems, how should we do it in Connecticut, what might this imply for other parts of the country who are thinking about similar issues of how to use transit in order to hopefully improve health outcomes and to substance use disorder outcomes, as well as minimize operating costs at the same time as trying to reach people and get people treatment who might not otherwise be able to get treatment. And sometimes that happens because of demographic issues. We will control for the demographics of clients overall at the provider level in our statistical analysis. The other aspect that's important to consider is the idea of economies of scope or specialization. For instance, and Dr. Rash touched on this earlier, if you have two different types of treatment that are going on, that some clients might need both, some clients might need only one, whether it's mental health and substance use treatment, or it could be different types of substance use treatment for different substances. The question is, does it make sense for a provider to treat both of those types of disorders in one facility together, or does it make more sense for the facilities to specialize and focus on what they can do best and have the clients go to 2 different providers to get the treatment that they need. And then so that's something that's been looked at before in the literature on substance use treatment costs. But the innovation here is when you introduce transit, how does that impact the optimal approach? We don't know, but that's a very interesting question to study, because this could be another motivation for considering whether or not we need to, or to what extent we want to encourage aligning systems, transit with public health and the medical sector, which is in this case substance use and mental health treatment. And this is just a picture of what that might look like. So the gray sort of ovals at the top of the slide, MH is mental health, it should say SU is substance use. So in the blue bordered box on the left side, you have a provider that treats everybody in the same place. It treats mental health and substance use in the same place, okay? And then you can go down a little bit lower in the flow chart and ask the question, does that provider have strong social services, which in this case is transit? If the answer is yes, you'll get an estimate of the costs. If the answer is no, you'll get an estimate of the costs. You go over to the right side and you have 2 different blue bordered boxes, one for a provider that treats only mental health and then another that treats only substance use. And then you ask the same question again, are there strong social services? In other words, strong transit in proximity. That will lead to cost estimates for both types of providers. And then you can compare, is it less costly to treat everybody in one provider, or is it less costly to treat people separately after taking into consideration whether or not there's transit that's reliable and convenient? And then that also will hopefully inform the advisory panel in terms of whether or not more transit or makes sense, or maybe we want to change transit schedules or encourage the advisory panel members who are able to advocate for that, encourage them to change the transit schedules or possibly modify the routes a little bit to try to lead to a more efficient situation. So where are we going to get the data for this? Because this sounds like a grand idea. At least in Connecticut, the state substance use agency, the Department of Mental Health and Addiction Services, has publicly available data for a large number of providers in the state, and it goes back to at least 2012, which is before the introduction of the CT Fast Track system. Currently, the data are updated quarterly and provided by the state substance use agency. We're also going to merge that data with IRS data that nonprofit organizations are required to fill out and are made publicly available through the IRS. So that's where we'll get the information on the operating costs of those providers, the number of employees. There's information there on the value of the physical capital, the buildings, the structures, et cetera. And the state substance use agency data has information on client counts, completion rates, outcomes, average demographics at the provider level, a very rich set of data that our state agency collects, and we're very fortunate to have that there. I didn't put this here, but we have the information of the locations of the new transit stops through work that collaboration I've been doing with the state DOT. We also have the data from Dr. Rash's previous studies, NIH-funded studies that have information on numbers of patients at different providers that have driver's licenses, which we can control for instance. And while the primary area of the focus is Connecticut, we want to be able to have generalizability to other states. So we've been able to collect some data from Minnesota, and we're in the process of discussions with the state substance use agency in New York to obtain data for providers in New York State. And that is a good opportunity for me to say that if any of you who are watching this presentation today are from state substance use agencies or state addiction services agencies, and if you have data like the data that we were just describing for Connecticut, and you would like to be a part, have us use your data as a part of this, we would love to hear from you afterwards. So please reach out to us if that's the case. So just to summarize, what is it that we're going to look for? We're going to look to see whether or not transit improvements lead to lower costs per client. We're going to look to see whether or not it's more cost effective to treat mental health and substance use clients together in one facility or not, and how does the answer change depending on the new transit improvements. We're also going to look at equity issues. What are the treatment outcomes for different demographic groups, and how do they change in response to the new transit? And finally, we're also going to try to consider the financial incentives, and this is something we'll raise with the advisory board. If we see that providers' operating costs are lower after new transit is initiated, then we can ask the question, well, maybe we really want more transit and better transit, so maybe if we know that that additional transit is likely to reduce operating costs even further, maybe some of the providers are willing to help pay some portion of these reduced costs in order to encourage new transit. And that's related to an idea called value capture in the urban economics literature. So that's how we'll get at the financing aspect of that. And so we already talked a little bit about, what do these answers imply for system alignment. We're going to have regular advisory panel meetings to guide the research based on real world things that are going on at the providers and at the state agencies, and to try to work together to align systems to improve the opioid crisis, reduce treatment costs, and improve outcomes for underrepresented groups. And then finally, we're going to write and publish academic research papers and present findings at conferences and at additional webinars like this. And then in the end, towards the end, we're going to host a symposium in Connecticut, which hopefully by then we can do it in person, but it may also be live streamed so that people throughout the country can see, what are the findings that we have come up with, and we can demonstrate the effectiveness of our proposed approach to a system alignment. And hopefully by then there will actually be some alignment that's occurring as a result of this. So now I'll turn it over to Steve Huliat, who will be the commentator.
Thank you, Jeff. Thank you, Carla. Good day to everybody. I'll pleased to be part of this project and happy to assist Jeff and represent the panel on today's call. I think for those of you, since you're from all over different places, I'll just want to touch base quickly on Connecticut a little bit. Connecticut is a home rule state. We do have counties if you were to look at data or if you were to look at a map, but there is no county infrastructure. There's no county seat, no county administrators, none of that. Most of the county data is captured in order to satisfy federal grant requirements more than anything else. So we're a home rule state, so there's 169 municipalities and 2 tribal nations in roughly 8 county units. A lot of the infrastructure that Jeff showed, specifically the busway, is all confined in Hartford County, so that may help us looking at county data at that point. But with the home rule aspects of the issue, it makes it a little more challenging when we look at a transit system that goes through many towns. So we need to be able to reach out to, when we move forward with any recommendations, we're going to need to be able to do that across many towns. And the state agencies that were listed are obviously going to be critical to help with any of those kinds of changes, specifically DOT, which is in charge of these transit systems here in the state of Connecticut. The state agencies, as you saw on one of the slides, have a variety of different interests or points of view with who is doing mental health and who's doing substance abuse. And it'll be interesting to look at the policies associated with the different agencies and perhaps those different funding streams that those agencies control as to what they can allow or not allow in some of these perhaps reimbursement of transportation costs, as Jeff was saying. But we have a good breadth on our committee. Jeff introduced everybody earlier. So we have the right state agencies at play. We have the right practice people at play. And we can always bring in some other subject matter experts as we identify what the research is bringing to us, so we can inform the research a little bit better. The local health department situation in Connecticut is as unique as that home rule situation. So there isn't a county health department. So all these towns either have their own municipal health department, or in Connecticut, you're permitted to join as 2 or more towns and form what's called a district. So the two things operate relatively the same. They enforce pretty much the same state regulations and prevention and promote and protection ideals, but there are also local initiatives that some health departments have that others don't. All the towns generally in Connecticut have a substance abuse council, and those substance abuse councils may or may not be able to provide some insight into the research, or we may wish to have get a reaction from them as we move through this. Connecticut is a strongly, or at least the area in which we're looking at the transportation changes, is very strong zoning rules and laws. So that may impact not necessarily the transportation change, but it certainly may impact the location of where the providers are situated. The non-governmental organizations in Connecticut, and I think across the nation, did not fare well during the Great Recession that we finished just before we ended our pandemic, with many foundations that supported them losing their funding, and with federal funding drying up. So some of those locations of substance abuse programs may also have either consolidated or retracted in some bit. That I think as we look at the data over time, Jeff, from that 2013 to now, we might need to just look at what sorts of environmental changes happened in the substance abuse community as well. Strongly, the health equity issue that Jeff just mentioned is critical to make sure we understand that, that we review that, we document that, and we eliminate that if possible with transportation initiatives. I am a practitioner of systems change. I've been involved also with Jeff on the previous Robert Wood Johnson projects and the practice-based research network in Connecticut. And I think one of the questions was that I see in the chat room was, how much our advisory member is going to be able to put forth and implement change. Well, that change will happen by community engagement here in Connecticut. So we need to be able to take the research and marry that and inform practice and policy, and then to take that practice and policy to the appropriate legislation, be it local elected leaders or be it the state elected leaders, and make them fully informed as to the benefits or the changes that would benefit the substance abuse initiatives and make it more cost effective and more efficient for all. On the local health side of things, public health in Connecticut wasn't so engaged in substance abuse as the other state departments for a while. It was engaged, but not deeply engaged. The opioid crisis in Connecticut was quite stunning, as it was for the rest of the country. On the state health department's point of response, they've been able to develop much stronger surveillance systems for overdose situations, that's for sure. But the Department of Public Health hasn't really engaged much in case management. That's been more of the other state agencies. So as we look at costs for case management, that side of the equation would come from the other agencies. And hopefully our community advisory panel can bring that data to the research committee so that they can see how that case management costs versus population-based strategies on response to overdoses is working out. So that program encompasses everything right from EMS hospitalizations on the DPH side, which I'm more familiar with at this point in time. So that data is available. It doesn't really look at treatment. So I think the exciting part for me is to learn much more about the treatment community with this and to find out what that impact of access through the transportation system can mean. The point that was made that so large number of the clientele do not have access to cars. Connecticut is been dominated by the Eisenhower highway system, interstate highways expanding into suburbia. And the two transportation systems that Jeff referred to are brand new. They did not exist in any way that you could do that, 10 years ago, shy of, as I guess Carla was saying, you had to take a local bus through all kinds of stops and starts to get someplace and transfers. So that's definitely a new feature that should be quite helpful. The issues of the walkability of where the centers are, I would hope we can take a look at too. So just because you can get near a treatment center, is it walkable to get to from the stop to the center? And is it perceived as being safe? A lot of the walkability work that I've been associated with in the region, one of the factors oftentimes is safety. Do you feel safe walking from A to B? And what would that look like as part of just the transit strategy? Trying to make improvements in the safety of the neighborhood, be it street lighting or whatever it might be. I think that's pretty much what I was hoping to introduce as to the status of practice and policy in Connecticut. And with that, Jeff, I'll take a pause and see if there's something you or Carla would like to react to what I've said. And I'll take a quick look at what else is coming in our chat room here. Are we still there? Did we lose me?
I'm sorry, I was muted. Thank you very much, Steve. Your comments are very insightful, and I think we'll be really fortunate to have you leading our advisory panel throughout this study. I agree with the walkability issue. Some of the preliminary analysis we've been doing in the last few weeks, in addition to having one panel meeting already, we've been starting to look at some of the data a little bit, trying to get a sense of where the providers are located relative to some of the stops in some of these states. We've been looking a little bit at Minnesota, just because we have the data in electronic format already, while we're waiting to get the Connecticut data in electronic format. And one of the things we initially saw is that there were some new transit lines in Minneapolis, for instance, but they're like 1.5 miles or 2 miles away from the provider. So we zoomed in a little bit more closely, and we noticed that there are local buses that go from the new transit lines to right across the street from where some of the providers are located. So even though those local bus lines were already there previously, having the new subway line, for instance, it opens you up to a broad range of additional potential clients that couldn't have accessed easily the providers before the new connecting lines were there. So I think you're exactly right. We need to dig a little bit deeper, and there's a lot of underlying detail to try to look at carefully. And I think in Connecticut, it's a similar issue with the CT fast track bus rapid transit line. There are some of the buses at some of the stops connect to other buses that would make it easier for people to be able to access providers that are not right at the CT fast track stations. So these are all really great issues.
This is Carla. I'll just add that some of these concepts seem very abstract, but they have very real implications for our patients. And the system for some is sort of set up against them. If they have to wait for hours to get to a, an hour, many hour long process to get to the clinic, receive treatment, and then wait for the next bus to get home, we're basically setting them up to be incapable of holding a full-time job and seeking treatment at the same time. So these transit alignment with the treatment sector have very, very real implications for our patients. And I just wanted to emphasize that part of it.
Yeah, Steve again. I would just add how important I think it'll be for the community advisory panel to help in the early stages to inform and the research team. But ultimately, it's going to be the research team that's going to help to inform us as the community advisory committee as to where that systemic change can be made and what buttons can we push. And if we can make the buttons push correctly and make policy change, then it'll be lasting, they'll be sustainable. So I think that's ultimately what would be a great success for this program. As a public health practitioner, I would love to see us also develop a better model for public health and behavioral health to come together. It's not a strong, well-documented component inside of public health. To have public health, behavioral health as a population-based program. So opioid response, I think, started that kind of discussion. But again, with the home rule issues, every town thinks they don't have a problem. They think it's the town next door's problem. So it would have to be done through probably more of a state type of response to get something done. But that said, that would be my optimal win-win would be that we eliminate health disparities doing this, obviously improve substance abuse, and do it in a way that is sustainable through policy change. But maybe I asked for too much.
Well, I think that's what we're aiming to do here. So I think that's we have a very good start. We have a great advisory panel. We have access to excellent data resources at the state and national levels, and I'm excited.
Okay, Sadina, with that, I don't have any other comments unless Jeff or Carla have any final thoughts.
Thank you, everyone that attended.
Yes, thank you.
All right, thank you so much to our presenters, Dr. Cohen and Rash, and also some fantastic commentary from Mr. Juliet as well. In the interest of time, I'm just going to jump straight to some announcements. If you have any additional questions for the presenters today, we've included their contact information on the slides, which we'll be sharing with you afterwards, and will also be made available on our website, systemsforaction.org. And if we can move into a few quick announcements. For folks who are interested in receiving a certificate of completion for today's ResProg webinar, there'll be a survey at the end of this session, and one will also be provided to you via email. So please fill that out if you'd like to receive a certificate of completion. And if you are interested in our funding opportunity, Systems for Action will be providing supplemental research funding to teams that are already engaged in the study of a promising systems alignment mechanism. We're looking to learn how the mechanism will perform in addressing health and social needs during the COVID-19 pandemic. If you are interested in submitting a proposal, the deadline is August the 5th. And you can find additional information and FAQs on our website. at systemsforaction.org on our funding opportunities page. And if you enjoyed this webinar, which I'm sure you did, we have more coming up. As always, at the same time, August 5th, we'll be hearing from our team at Washington University in St. Louis. They're investigating systems alignment of multi-sector agencies to address child maltreatment in St. Louis. The next will be August 19th. You'll hear from the intramural research team here at the Systems for Action National Program Office. Glenn Mays will be talking about how multi-sector community networks are shaping COVID-19 pandemic trajectories and outcomes across the US. You'll definitely want to tune in for that. So thank you again for participating, and we look forward to seeing you, or at least having you join us on August 5th. Enjoy the rest of your day.